All right, everyone, welcome back to ICU. I'm really excited. Today we're going to be talking about bladder pain, bladder burning, and who better to talk about this with than a urogynecologist. So today I have Dr. Nabil Noor with us, and she's actually local to where I live, which is crazy. But welcome to ICU, Nabila.
Yeah, thank you so much for having me. Super excited for our conversation.
Yeah, so I honestly forget how we even connected in the first place. Was it like LinkedIn or Instagram?
I think it must have been Instagram because, because now that, I'm being more active on social media because I love doing contents, basically education contents, right? Creating awareness for women's pelvic health. And I think, how you just get pop-ups because you're kind of in the same field. And then I was like, oh, this is interesting because, I do have a fair amount of patients who struggle with bladder pain syndrome. And as we were talking about before, it's a difficult diagnosis, right? Because we have very limited options of what we can provide. So I'm always curious about what are some alternative treatment options for patients, who can I refer patients to that could give them value? And yeah, I just kind of looked you up and I was like, oh my God, you're in the Lehigh Valley. That is wild. And yeah, sent you a message and here we are.
Here we are. We have a new friendship blooming here.
Yes, yes. No, I'm super excited. Super excited for our patients, actually.
Yeah, for sure. Me too. So, my audience here is primarily people with interstitial cystitis or symptoms of IC, but I think we also have a mix of people with OAB and just other bladder related symptoms. So, I really thought it would be a good idea to discuss the topic of bladder pain because that is something that a lot of people are struggling with. It was actually my main symptom back when I was struggling. And so, for the people who are describing their symptoms being like a burning sensation, a pain sensation in their bladder or urethra, like let's start out with what could be causing this and also how is it different from like a urinary tract infection?
Yeah, no, great question. And this is something that comes up in my office all the time. And it's also like a difficult thing for patients to understand the difference, right? So simply put, like when we're talking about interstitial cystitis, now I love the fact that you referred it as bladder pain syndrome, which is the new terminology, because I do think that kind of encompasses the symptom a little bit better than, say, interstitial cystitis. Because traditionally, when we talked about interstitial cystitis, we referred it to as an inflammatory process, and hence the word cystitis, which essentially means inflammation of the bladder. Now we know better, and we know that interstitial cystitis, it's not just inflammation of the bladder wall, it's a lot more broader than that. And that's why using that terminology, the bladder pain syndrome, kind of encompasses it a little bit better because there are different etiologies of why it happens. It's not just inflammation. Inflammation is just one cause. There could be, hypersensitive nerves that causes it. There could be, vaginal atrophy that causes a lot of the irritation. There's a thought that it could be, almost like an autoimmune kind of disease, your own immune cells attacking your bladder wall. You have mast cell activation. So when we're talking about bladder pain syndrome and what causes bladder pain in that particular diagnosis, we're talking about all these things. We're talking about the inflammation. We're talking about the hypersensitive nerves. We're talking about the mast cell activation, all this that could be causing the burning and discomfort. Now, a UTI, which is a urinary tract infection, very different, a little bit simpler. So that's essentially caused by bacteria. So a bacterial infection means there's bacteria present in your urine, which is causing irritation of the bladder wall, and that's what's causing the inflammation. So the symptoms are similar, meaning you're having the burning and the pain, but the etiology and the causes of it are very different.
Mm-hmm. So let's say that somebody has bladder burning, they have pain, um, and they got tested for a UTI. That urinalysis came back negative. Doctor saying they don't have a UTI, or I guess in this case, I'm gonna call you their doctor.
Yeah.
How would you proceed with a patient like that? Like, what are your next steps following a negative urinalysis, but they're symptomatic?
Yeah, absolutely. And, first of all, you have to kind of address So when we have somebody who's presenting with symptoms, like you said, whether it's burning, discomfort, you want to rule out the obvious things. The obvious things being an infection, right? And the easiest way to rule that out is by doing a urine culture, not a urinalysis. And I want to emphasize that, not just a quick dip in the office, because sometimes patients will tell me that, oh, I know I had this burning and discomfort, and my doctor did a test in the office and it was negative. So just to clarify for your audience, a urine dip is what happens in the office. That's a quick and dirty way of saying that, okay, does your urine look abnormal? But the best way to know whether or not you truly have an infection is by sending your urine for a urine culture. And that takes a few days. So if somebody tells you, oh, your urine culture is, your urine is normal, and they tell you right then and there, that's not a urine culture, right? So very, very important to make sure you get a urine culture done, because when we do a urine culture, what we're looking for is whether or not there's bacteria growing in that sample. And, to your point about a UTI, if there's bacteria growing, that's when we call it a urinary tract infection. Now, yes, if somebody has burning and discomfort, but their urine culture comes back negative, then you kind of have to, put on your thinking hat a little bit and think about, well, why are they still having symptoms, right? So then you kind of have to go down your list. Is it because of bladder pain syndrome for the reasons that we talked about earlier? Is it because maybe the patient is menopausal and they have a lot of vaginal dryness and irritation, what we call vaginal atrophy, that's causing some of their discomfort? Does this patient have a lot of myofascial pain or pelvic floor tightness, because of which they're not relaxing, and that's causing that sensation of pressure and heaviness and discomfort? Like, there are a lot of other non-infectious etiologies of why somebody can have bladder pain. So you kind of have to go down that list and rule those out.
Yeah, my main symptom was bladder pain. And when I learned that my pain was being caused by my pelvic floor, I was like totally mind blown because I
Yes.
couldn't wrap my mind around the idea that my pelvic floor muscles were causing my bladder to feel painful. It felt like
Yes.
a bladder issue. It felt like there was something wrong in my bladder. Like, let's say I have Hunner's lesions, but no, I
Yeah.
didn't. My muscles were just really tight.
Yes, well, absolutely. And that's a very important point, right? And that's why I love the new terminology, because it takes the focus out from just the bladder and also to the surrounding structure. So now we know that people with interstitial cystitis, rather than just focusing on the bladder, it's more of it's a part of a chronic pain syndrome where, yes, bladder is one of the organs that gets affected, but also the additional or, excuse me, adjacent pelvic floor structures, which is your pelvic floor muscles. For a lot of women, they'll just have lower pelvic pain. So when they have a flare up, it's basically that whole area, that whole pelvis is in pain. So, it's the bladder, it's the lower abdomen, it's the pelvic floor. All those is connected. So yes, even now when I tell patients, sometimes they look at me like I have two horns. They're like, I'm talking about my bladder. What are you talking about my pelvic floor? So, there's a lot of education that needs to happen. And I think that's why I love doing what we're doing, because education is really empowerment, especially when it comes to this particular diagnosis.
Yeah, I think some concepts here can be difficult to digest, but I think conversations like this, where we're, bringing in real life examples, I think it's a little easier to grasp. Because if you told me this 10 years ago, I would have been
Yeah,
like, no, you're not listening to me. Like, it's my bladder. And then we
yeah,
both get frustrated. And, I feel like I'm not being heard. And I can imagine that that can be frustrating for you as a doctor.
yeah. And I think that's why, like, for somebody like you, who's not just an advocate, but you yourself are living the whole process. I think that's probably why, people find so much value from your work and, from your podcast, because they know that, it's not somebody who's just reading it in a book, or like, I don't have IC. I know a lot about IC because I've read about it. I'm treating patients. I'm talking to people like you. I'm trying to, widen my horizon of how to best treat my patients. But it brings a whole new perspective when you have somebody who has gone through it, kind of giving you their real life experiences and talking about what worked, what didn't work, and kind of being an advocate really for these patients.
For sure. And when we're talking about pain and burning, I think there's a couple different ways that that can present in people with these issues. Because for me, my pain was during and after urination, but there's a lot of people who have pain before urination that gets better once they go. So do you see a lot
Yeah.
of that?
Absolutely. In fact, you kind of hit it. And sometimes I'll use that timing of urination and the timing of their pain to try to see if I can kind of help differentiate between the different kinds of disease process that can cause the pain, right? For example, if we take a UTI, like we talked about, it's an inflammation of the bladder wall that's caused by a bacteria that's present in your urine. So that onset is sudden. You were fine, and all of a sudden, out of nowhere, you have this raging pain, and you are in pain all the time. You're in pain when the bladder is full, you're in pain as you're urinating, you're in pain as your bladder is empty, because that irritation takes it's basically the whole bladder wall is inflamed, and the only way to treat that is by an antibiotic. On the other hand, a lot of my IC patients, first of all, it's a chronic disease. So this is not something that's like, maybe it just got triggered by something, but maybe they've had prior episodes of it. And this is kind of more of like a chronic pattern. Now, a lot of the times patients will talk about certain flares, right? And you know this more than me, like there's certain dietary trigger factors, certain things that we eat. Stress could be a trigger factor, certain lifestyle activities or, exercises could be a trigger for some people. So there are triggers that causes it. And some people will tell me like when their bladder is full, they feel it, they feel the pain and discomfort, but once they relieve it, they feel better. On the other hand, my patients who have burning because it's vaginal atrophy, because their vaginal tissue is very dry and irritated, they will feel it worse as they're urinating. Because when that acidic urine touches that vaginal tissue, that burning and that rawness can cause a lot more discomfort. So sometimes like trying to, identify like the timing of their pain can give you some hints. It's not 100%, foolproof, but kind of gives you a little bit of, kind of like, a little bit of incentive to understand what's happening.
How easy is it for you to figure that out, like what the cause of the burning and the pain is? Because if, for example, with the vaginal atrophy, is that something that you see on an exam?
Yes. So great question. So I guess like, another way I'll answer this question is when somebody comes to see me, right? And they have these symptoms, how do I evaluate a patient? It's because I cannot just like take a history. And if somebody just looks at your history or hears your history and tells you you have a diagnosis of IC, with utmost respect, I beg to differ. That's not the best way to do it, right? Because yes, history is a big component, kind of listening to what the patient is telling you, what are their triggers, what causes the pain to get better, what causes the pain to get worse. But equally important is a physical exam. And to your point about how do you know if somebody's having vaginal atrophy, well, first of all, if I have a patient in the age group, I'm seeing that they're postmenopausal, that's already kind of playing in my head that that could be part of the reason. So after I do a good history, I start with a very detailed pelvic exam. And when I say detailed pelvic exam, it's similar to what you can expect at a GYN's office, but it's detailed because, I start from the external genitalia, like we're looking at it, we're looking at are there changes to the vaginal tissue, the color, the texture. So when we talk about atrophy, so normal vaginal tissue, it has a lot of rugae, which is basically folds. I mean, I joke about it, like wrinkles are only allowed in the vagina and the bladder, actually, because that is a sign of healthy vagina, healthy bladder. But if I'm looking at an atrophic vaginal tissue, the tissue like literally feels like it's like tissue paper. It's just very flat. It doesn't have a lot of vascularity. It feels very dry, very irritated. The easiest analogy is think about what happens to our skin in the winter if we don't put moisturizer, right? It just feels very friable. It's dry. It's irritated. Like even touching sometimes feels like it's going to bleed. So those are very classic signs that somebody has vaginal atrophy. And then, internally, when I'm doing an internal exam, I am touching and feeling those pelvic floor muscles. Because, like you mentioned before, you were surprised to find out that, yeah, a lot of your bladder pain is because you had such tight pelvic floor muscles. And there's no way I can look at a person and know if that person has tight pelvic floor muscles versus not, unless I'm actually doing an internal exam and touching those muscles. And, I always tell my patients, like pelvic floor muscles are just like muscles in any other part of the body. If I touch my biceps or my quads, I feel the pressure, but it shouldn't be painful. But somebody who has tight pelvic floor muscles, I touch them and they're screaming, and that's not normal. So those are some signs that tells me like, okay, this is a lot more complicated than just like a simple UTI or a simple like an infection.
Mm-hmm. Yeah. And I've been noticing in the people with IC that I'm working with, who have pelvic floor dysfunction or tight pelvic floor muscle specifically. I don't know if this is just a trend in my clients, but I feel like it's gotta extend outside of our group. But they are people who are very stressed. They are perfectionists, people pleasers. Like they identify as that. And I feel like it's gotta be something there. Do you ever notice that with your patients?
I do actually, and believe it or not, it's not. If you think about the etiology, I'm not surprised, right? So I'll give you another analogy. Like a lot of the times, many of my patients that I see with true IC or tight pelvic floor muscles are my super fit, athletic young women, who take great care of themselves. They're exercising a lot, and I'll tell you what my thought is. I think for so long we're told, especially as women, like you need to tighten your pelvic floor and you need to tighten your core. And those are all great. But remember, a muscle needs to relax, right? When we're doing bicep curls, right? If all you're doing is bicep curls, over time, that muscle is just going to be sore, and a sore muscle is not functional. Same thing can happen with your pelvic floor, right? When we're young, like the young gymnasts, the young athletes, people who do Pilates, like, very fit people who are exercising a lot, focusing a lot on core exercises, they are tightening those muscles. And over time, what happens is when you're just chronically tightening it and not relaxing it adequately, and of course, they're not doing it consciously, they're just not even aware of it, you create those tight bands and you create those tightness and basically those taut, almost like dysfunctional muscles that causes like, long-standing effects like we're talking about. And to your point about people who are stressed, I think it's just like people who like to get things done, right? Because you're busy, you're doing a lot of things and you want to get it done the right way. And what happens is when we're not relaxing these muscles the right way, you can have some of the problems that we're talking about. So yeah, no, I see it also in my practice for sure.
Yeah, as you said that, I had to unclench my pelvic floor muscles because it's just so automatic. Oh my goodness.
Yeah.
Yeah, and
Yes.
we are actually in my one program, we're doing a book club right now on the pelvic, or wait, no, the pain reprocessing therapy workbook. I don't know if you've heard
Right.
of it. It's new. It's
No, yeah.
fantastic. The
Yeah,
authors are
you can
actually
send
gonna,
me the name.
yeah,
Yeah.
yeah, yeah. And they were kind of digging into, that these traits that people have, like the people pleasing, the just being overly conscientious, being perfectionist, like these are coping mechanisms that our nervous systems have adapted or
Yes.
adopted that is
Yes.
essentially just trying to protect us.
That's so interesting. And we know that stress is a big trigger for flare-ups for IC or bladder pain, right? And I, the way I sometimes explain to my patients is, think of it this way. Like some of us, when we are stressed, we get a tension headache, or we get knots in our shoulders, or we get like a really tight neck. For women who are already prone to kind of having these kind of bladder dysfunction or pelvic floor muscle dysfunction, for them, it just concentrates on that pelvic floor muscle because again, it's a muscle, right? So when they're stressed, they just tighten that automatically. And again, it's not something they're doing consciously, it's just reflex. And over time, it just kind of gives out. And which is why we do see that connection that stress triggers it. Or like, maybe they're going through a lot, like they're trying to do a lot of different things and hustle, hustle, hustle. And, again, subconsciously, they're just kind of tightening and concentrating it on that pelvic floor. And once that pelvic floor muscles, because remember we talked about it's not just one organ, it's the adjacent organs too that gets affected. So now their pelvic floor muscle is flared up, their bladder is flared up, they have abdominal pain, and then it's just basically downhill from there.
For me, it's always the IBS flare up leads to the
Yes,
IC
that's a big
flare
one
up or
too.
vice versa.
Absolutely, because we see it, and that's actually a great point because when I'm talking to my patients about pelvic floor, because pelvic floor is basically my world, right? Everything I do, whether we're talking about bladder pain, incontinence, pelvic organ prolapse, bowel function, and I think we forget that the pelvic floor is not just support and it's not just for sex. It we need highly functional pelvic floor muscles to be able to urinate properly. We need good pelvic floor muscles to be able to have bowel movement properly. And so all those can be affected when your pelvic floor muscles are not working correctly.
Hmm. And when we circle back to the topic of like estrogen atrophy or did you say vaginal atrophy at some point? I want to say the right
Yeah.
term.
Yes, yeah, vaginal atrophy is fine.
So you were saying how that's commonly seen in postmenopausal women, but can it be seen in women that are premenopausal, like even as young as like in their 20s?
Yes, believe it or not, yes. So what happens is so atrophy or vaginal atrophy happens because of decrease in your estrogen level, right? So of course menopause is the big one because once women go through menopause, there's a significant decrease in their estrogen level. But that same symptoms can happen when women are pregnant or, right immediately after delivery when they're lactating because our body actually has a change in that hormone level as well. And in fact, now we have a new term. So we used to have the terminology called genitourinary syndrome of menopause, which basically encompasses the vaginal dryness, atrophy, the urinary symptoms such as urgency, frequency. And what we see is that a lot of these symptoms, we're also noticing it in young women who are nowhere near menopause. So the new terminology that they have coined is genitourinary syndrome of lactation. And in fact, when I have my newly postpartum patients, because a lot of the times, many of these pelvic floor dysfunctions that I treat starts or women first notice it once they've had their child and now they're noticing all these changes. So they'll come to me, and when I do the exam, like we talked about before, again, that exam and their tissue quality, it literally looks as if they could be postmenopausal. And in fact, I'll tell you, like, women will tell you, and this is also from personal experience, like trying to wear a tampon when you're immediately postpartum is painful. And that's because that tissue is so dry and irritated, pretty much similar to like in menopause.
Gotcha. So what are the treatment recommendations for people with estrogen atrophy?
Yes. So for vaginal atrophy, the best way to address that is by using vaginal estrogen cream. And, I'll talk a little bit about this because there's so much misinformation and there's so much fear factor about using estrogen. And I think, we really do women a disservice. So vaginal estrogen, first of all, when we're recommending vaginal estrogen, it's a cream or a tablet. Sometimes, some patients even use a ring. You're applying it vaginally. So it's not an oral pill that you're taking. You're applying it locally in the vagina. For example, if you're using a cream, you can use an applicator or use your finger, and you're using it in the vaginal opening. And actually, I recommend patients use their finger inside to kind of massage it into the vaginal walls. And so what happens is the vaginal tissue absorbs that estrogen and helps improve the quality of the tissue. So it addresses the atrophy, the thinness. For a lot of women who have urgency, frequency of urination, that some of those symptoms can improve as well. A lot of women will have pain with intercourse because of the dryness, so that can be helped. So vaginal estrogen is your go-to. And it may be surprising for some people to think, well, can a young patient, meaning somebody who's premenopausal, take vaginal estrogen? Absolutely, right? Like we talked about, I have patients who are lactating, and many women they are breastfeeding for 2 years. And for 2 years, do you want them to be in pain when they're having sex? No. A little bit of estrogen cream can really make a huge difference. The concern always comes up because there's been a lot of noise about, well, estrogen can cause breast cancer or it can cause blood clots. That's a discussion for a whole other day. But know that number one, oral estrogen is very different from vaginal estrogen because vaginal estrogen, when we apply it locally, the amount that gets absorbed in your blood is so low, it doesn't have a lot of the systemic side effects that women fear of. And also, a lot of these things that women have been scared of, whether it's the blood clots being caused by estrogen or breast cancer, it's a lot more nuanced discussion to have. So I think if you're somebody who is concerned about that, I would highly recommend talking with your gynecologist, or if you happen to have access to a urogynecologist, talk to them what your concerns are. They can do a good history, take your family history into consideration, take your specific risk factors into consideration, and give you a more appropriate answer of whether these risk factors are appropriate for you or not.
I was just thinking, because I'm pretty sure when I was in my early 20s, someone, a urogynecologist, maybe somebody different, but I'm pretty sure they prescribed me estrogen cream. Is that is that weird?
No, not necessarily. A lot of the times, say women who are on birth control pills, they can also notice that they have a lot of atrophy. And I should have mentioned that over there. So,
Mhm.
yes, so young women who are breastfeeding, that's one type, but also, certain oral contraceptives. Because again, remember, oral contraceptives work because it decreases or, kind of plateaus your hormone and keeps it at a stable level as opposed to the normal spikes that happens when we're going through a normal menstrual cycle. So, a lot of women, I do see when they are on, birth control pills can also have some of the symptoms of vaginal atrophy. And again, I don't know your specific situation, but to your point about was it wrong? I wouldn't say it's necessarily wrong. Again, depending on what their reason was, but if they felt that maybe you had atrophy or the tissue didn't look very healthy, maybe they were prescribing it to you to kind of help you with some of the things we're talking about.
Yeah, that makes sense. I've also been digging into some research recently about the effects of like chronic stress on sex hormones, so estrogen,
Yeah,
progesterone, and it seems
yeah,
like that does have a pretty direct effect on, your hormones and in people who are maybe in their 20s or 30s. They're
yes.
not like having kids yet or anything, like having hormone issues. Do you see any of that?
You know, yes, no. So to your point about stress, yes, I mean, stress is a big trigger for so many different things. I mean, think about how much infertility we have to deal with, and again, I'm not an infertility specialist, but I do believe that a big component of that is stress, and kind of how we live. Um, I don't in my practice. I haven't had a lot of young women that I've encountered with, say, what you're describing, chronic stress. So I probably am not in the right position to say like I see it in my practice, but I can absolutely understand why that is because if you kind of think about the pathophysiology, if you think about kind of like the reasoning behind it, it makes complete sense for sure.
Yeah. And one of the side effects that I've heard somewhat commonly on like support groups for IC is that people are using the estrogen cream. I feel like I hear estradiol come up a lot and they notice an increase in their burning. Is that normal?
So that's actually a great question, and I think it's worth investigating a little bit. So the estrogen itself may not be causing the burning, but what kind of preservative it's on, or the kind of the formulation that it is based on, can sometimes irritate patients. So, for example, there are different forms of estrogen, like we talked about. There are the creams, there are the tablets. Premarin is one of the estrogen cream, and I believe it does have a little bit of an alcohol base that they use to make the cream. And some people are more sensitive to that, so they can, if there's a little bit of alcohol, that can cause a little bit of burning for patients. Sometimes what I'll do is if I have a patient who complains of discomfort or burning, I'll change to a different formulation and see if that works better for them. And sometimes, if somebody's really sensitive, you can even work with some of the compounding pharmacies and they can just kind of make it exclusively for that particular patient. And of course, with compounding pharmacy, it can be a little bit more expensive because they're making it exclusively for you. But to your point, I don't think it's necessarily the estrogen that's causing the burning. It's probably just the formulation. So there are ways to go about it. So I wouldn't just not use the estrogen if you need it because you think that's what's causing the burning. I guess that's the point I'm trying to get across.
Okay, yeah, that totally makes sense. So,
Yeah.
in people who have low levels of estrogen, that makes them more at risk for getting urinary tract infections, right?
Yes, and I see that so commonly. And in fact, uh, postmenopausal women being postmenopausal is a big risk factor for developing infections and, in fact, developing what we call recurrent urinary tract infections. So, recurrent urinary tract infections are women who are getting two or more infections in 6 months or three or more infections in a year. You have an infection, once in a lifetime, no big deal. You get your urine culture, you get treated with antibiotics, and you're fine. But I'm talking about women who are getting it on a monthly basis and they're miserable. And these are true infections because, that you do a urine culture, there's bacteria growing. And yes, to your point, that low estrogen, what happens is when there's a drop in estrogen, the vaginal flora changes. In every woman have bacteria that in their vagina that's protective for their body. So when you have a drop in estrogen, there are changes to the pH that happens to the vaginal area, and that also leads to like a changes of the good bacteria, and then you can have an overgrowth of essentially the bad bacteria, which a lot of the times is E. coli. That's what's causing infection. So when you're postmenopausal and there's a change in estrogen and you're getting a lot of these infections, a lot of the times the first line of therapy, like when I see patients, is me starting them on vaginal estrogen cream. And it's amazing what just a little bit of estrogen cream can do. And patients are amazed. They're like, oh my God, like I didn't get infections in so many months since I started the estrogen. But the key is to make sure you're using the estrogen correctly, you're using the right dosage, because a lot of the times patients will come and tell me that Dr. Noor, like I've used estrogen, it doesn't work. And I'll ask them, okay, how are you using it? How much are you applying? And they'll tell me like, I take a little bit and just put a little dab. I'm like, no, 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 you're going to need more than that. So, it's a little bit of like, making sure patients are really understanding how to use it. And a lot of the times we can use a pH paper to see if there are changes happening in the vaginal pH. But yes, vaginal estrogen for postmenopausal women who are getting a lot of infections can be a total game changer.
Okay, awesome. I think that's going to really help a lot of people in my audience because I don't think
Oh,
this
cool.
topic gets discussed a lot in at least
Yeah,
in the
that's
IC
awesome.
community.
Yes. And I think, sometimes what I do see where I think it can get confusing for patients and also for physicians is, you have these patients who probably have bladder pain syndrome and now they're postmenopausal and now they're getting infection. So there's like, is it IC? Is it the infection? What's causing the pain? What's causing the burning? It can get a little confusing, but what I usually suggest is that's where it's so important to have that relationship with your provider, with your physician, where you feel comfortable discussing your symptoms. And, it's a work in progress, right? It's not, I wish it was an easy diagnosis where, I just give a medication and, we're done. That would make everybody happy. But unfortunately, this is one of those things that does take time. And, I tell patients it's basically a journey that we're taking. And there's a lot of trust. There's a lot of understanding. And I'll be honest, there's sometimes I'll tell patients, I'm not sure like why this is happening because everybody wants answers just as I do. And, we're all learning through this.
Hmm. And I kind of have a random question, but it's not that random. In people with vaginal atrophy, how how can you differentiate that from like vulvodynia and vestibulodynia, like those types of diagnoses?
Yeah, yeah, no, that's a great question. So I think a lot of it depends on the context, right? For example, if somebody is menopausal, kind of more thinking in the realms of vaginal atrophy. And again, vulvodynia, the vaginismus, those are a little bit different. From vaginal atrophy, like I talked about, there are some classic appearances, and you've seen enough tissue that's vaginal atrophy, like when you see it, it's not subtle. And of course, like an age, right? Like if somebody is, unless they're young and they're breastfeeding, or maybe they're on birth control pills that's causing the atrophy, it's unlikely they have vaginal atrophy if they're not postmenopausal. Now, vaginismus or vulvodynia, a lot of the times it's the pain is very localized, right? So say, for example, for vulvodynia, a lot of the times, I'll take a little Q-tip and then basically touch like from the external genitalia, and it's very specific, pinpoint, right? Like it's right just at the vaginal opening, which is why a lot of patients with vulvodynia have so much difficulty with penetration because it's right at that tip. So if you can isolate, like, okay, is it just in one part versus atrophy, which is more global? So those are some things that can tell you how they're different.
Okay, yeah, that makes sense. I was just wondering like it looks different, which it sounds like it does.
Yes, it does. Yeah. And there, like I said, and that's where, it's helpful to go to somebody, maybe who has more experience. Like, if you're somebody who's dealing with vulvodynia or vaginismus, there's a lot of gynecologists, even locally who focuses on that. And that's basically their specialty. And so if you've been going to a lot of people and not getting a lot of answers, maybe good to seek out somebody who specializes in that so that they can do a little bit more of a thorough exam. And similarly, when I have patients, who are dealing with pelvic floor issues, yes, your gynecologist can probably screen you, but it is helpful when you come see a subspecialist like myself because this is what we do all day. But of course, we see a lot more patients, so that enables us to be able to differentiate those nuances that sometimes is really necessary to diagnose patients.
Hmm. Right. So, for somebody who is diagnosed with interstitial cystitis, painful bladder syndrome, and they are having some serious pain, they're in a flare up, but they're not sure if it's like 100% a flare up or is it a UTI, what do you recommend that they do in that scenario?
Yes, and that is actually an amazing question because you're right, especially for patients who have been dealing with a lot of IC pretty much for a major part of their life. The tendency is like, oh, I know what it is. Like, I don't want to have to go through this because it's frustrating sometimes for them because they know what the treatment is and it may or may not help them. And the natural knack is, I just want to take care of it. But I would absolutely urge everyone that, if you're fine, but all of a sudden something just got triggered up, meaning you're having new onset symptoms, first of all, always start with a urine culture because you could be a patient who's suffering with IC all their life and could have an infection, right? And you don't want to miss that because not treating an infection with an antibiotic could potentially cause you to get really, really sick. And sometimes I will see patients who end up being septic from just a simple UTI that wasn't treated, and now they're in the hospital, right? So
Yeah.
you want to avoid that kind of a situation.
I've seen people in Facebook groups that are like, is a fever normal for a flare? And I'm like, no, it is
Oh no.
not.
And correct. And and a lot of that is, education, because I'll tell you, because sometimes, especially when I'm on call and it's over the weekend, I'll get a call and patients and they're like, oh, Dr. Noor, I know this is it. Just treat me in this. And I'm like, I understand it. I'll be happy to treat you, but do me a favor, just do that urine culture just for me. Please, pretty please. Because, I don't want to miss an infection. And, primarily for the reasons we just talked about, because you don't want somebody that have a simple UTI and then end up being septic and ending up in the hospital. Because I see that, it may seem like a far-fetched thought, but things like this happen, like especially for my postmenopausal patients who may be diabetic. There are many young patients who may be diabetic because there are risk factors so it doesn't take much for you to be pushed over the edge. So that's number one. If your urine culture is negative, so now we're really thinking that it's the bladder pain syndrome. If you're somebody who have been treated before and you know what works for you, great. Talk to your physician, whether it's a your certain medication, whether it's a bladder instillation. There's a lot of treatment regimen. I have many patients who have been dealing with this for years. They know what works for them. They will actually call our office and be like, I'm in the middle of a fair. Can we schedule for this? And we're kind of getting them on board. If this is a new onset thing, meaning you've never had this, and now all of a sudden you're having pain, burning discomfort, nothing's improving, you want to be evaluated. Again, you want to kind of have, just like what we talked about before, you want somebody to do a pelvic exam, assess your pelvic floor muscles, make sure there's no other concerns that's happening. And for a lot of my young patients, right, I would urge you, like if you are fine and all of a sudden you're having excruciating pain in the pelvic area, I mean, simple things. Make sure you take a pregnancy test. You'll be amazed how often we forget that pregnancy can present in weird ways. Now, if it's a normal pregnancy, great. But God forbid you have an ectopic pregnancy. Maybe you're having a ruptured ectopic, right? So you don't want to forget those simple things and just say, oh, it's just icy because you've dealt with it for a long time. Or it could be a ruptured cyst. It could be ovarian torsion. So there's so many other things. So if there's pain that's not getting better by some of the normal treatment that you do, or you're starting to notice blood in the urine, or you're starting to notice blood vaginally, make sure it's not an infection. Make sure it's not a vaginal infection. So there are other things that you want to rule out. But so getting evaluated would be highly recommended.
Yes. And you actually, I wasn't sure if we were going to talk about this, but I think this is a great segue into that. You just made a video on Instagram that was like, vaginal infection versus bladder infection, and you were like top
Yes.
five signs to look out for both. Can you
Yes.
kind of take us through like what are the common signs and symptoms of both types of infections?
Yeah, I actually did that video because it comes up, and not just from my patients, but from friends and colleagues and family members, right? Because, they'll say that, okay, I have pain down here. So is it an infection? Is it a vaginal infection? And the truth is, yes, the best way to know it is by doing the test, but there are some telltale signs that can give you some clue. For example, when we're talking about UTIs, right? classic UTI is that, you're feeling a lot of urgency, frequency, not being able to hold the urine. You were fine yesterday, and then all of a sudden you can barely hold urine. So that's classic. Then you have burning with urination, right? You were fine, but now when you're urinating, there's burning and discomfort. Blood in the urine, that's never normal, right? Blood in the urine is a red flag, whether it's because of a UTI, whether it's because of an IC flare, or worse, like, it could be a bladder tumor, right? God forbid, or kidney stones. So you don't want to just say it's normal. Cloudy and foul smelling urine, right? Your urine should be looking like clear, straw colored, not like clear white, because that means you're just drinking too much water, but that pale yellow color. But if it's looking like cloudy, like, oh, there's this really strong odor, that's not normal. And then also sometimes, I have, especially my older patients, they'll say, Dr. Noor, when I have a UTI, I never have any of this burning and discomfort, but I just don't feel well. So that vague symptom of like, I don't know what it is. I'm just not feeling 100%. Maybe you have a fever, maybe you don't, just feeling yucky. Especially for my older patients, like my postmenopausal patients, that always kind of, worries me a little bit, because again, remember we talked about people can get septic. So if that infection is already in your in your system, meaning it has kind of traversed the bladder wall, you can have a little bit more of this generalized like symptoms, which again, you want to make sure that it's not an infection. So those are for the UTI. Now, vaginal infection, again, talking about discharge, normally a little bit of every woman has a normal vaginal discharge. That's just normal. For some of us, it can be more clear. For some, it can be a little bit more white. But when you have a true vaginal infection, that color of the discharge changes. Some of the most common vaginal infections we talk about is BV, which is bacterial vaginosis, which almost gives out this grayish discharge. You could have a yeast infection, and then the classic terminology we use is cottage cheese, like almost this white, curd-like discharge. Of course, you can have, sexually transmitted diseases, whether it be gonorrhea, chlamydia, or trichomonas. So those are when you're starting to see like some funky looking greenish, yellowish discharge. That's not normal. Bleeding, vaginal bleeding, that has nothing to do with your menses, right? I mean, this is not time of your cycle, but you're randomly bleeding. It could be because of the infections. Or pain with irritation or pain with intercourse. You were fine 2 days ago, but now when you're trying to be intimate with your partner, you're noticing that it's a lot of burning and irritation. And then sometimes, that odor, like, your discharge, normally, every woman knows what their discharge smells like, but all of a sudden there's a change. We'll talk about certain terms like fishy discharge, like fishy smell. That's very classic BV. Or like a yeasty smell because, it's a yeast infection. So those are some differences between the two that can help kind of identify the differences.
Okay, got it. So, is there a particular practitioner that they should go to based on which symptoms they're experiencing?
Yeah. So I think, if it's a classic UTI, like, you're having burning discomfort with urination, your primary care doctor can be an easy person to access. I mean, everybody has a primary care doctor. And if that's somebody that you can reach out to quickly, that's a great place to start. Now, a lot of primary care doctors sometimes do women's health. So if they are already doing women's health and they can do a vaginal exam and then kind of do a swab and a culture, that's great as well. A lot of my patients don't have a primary care doctor, but they have an OBGYN. And that's a great resource to start with, right? But my point is, do not ignore this sign or self-treat yourself, because any of the changes that I talked about is not normal. And you do want to kind of check your urine. You do want to do a vaginal swab and a culture, because a lot of the times too, like even say I'll hear it from friends and colleagues like, oh, I think I have a vaginal infection and they just gave me a medicine. They never really did a swab. I mean, I can kind of understand why that would be the case, but the best way to know whether or not you have an infection, what kind of infection, is by doing a culture, whether it's a urine culture or a vaginal swab and a vaginal culture. Because again, remember, if it is a true STD, and depending on what kind of STD, your partner may need treatment. So you don't want to just assume that, okay, it's bacterial vaginosis and not an STD. So, your gynecologist should be able to do all that for you. And a lot of the times, if you're in pain, what I'll do is I'll do the culture. So while we're waiting, I'll kind of start them on a treatment, because I know like it's very classic UTI. And then if we need to change the antibiotics, we may change it later. But definitely get the cultures done.
Okay. Think we covered everything we needed to there. So if we move back to people with painful bladder syndrome, just anybody who's having bladder burning that I guess we'll exclude like the vaginal atrophy people. Like what are things that you are recommending for this patient population in terms of like medications? Are you doing supplement recommendations? Anything past that?
Yeah, no, that's a good question. So I think the treatment algorithm, because before, I think like probably even 5 years ago, we used to have a very algorithmic way of treating bladder pain. Meaning, like number one is lifestyle modifications. Addressing like triggers, whether it be dietary triggers or stress. You kind of address that. That's the first line. Then we go to medications. Then we go to more invasive therapies. Now the recommendation is, because we know that different things work differently for different people, right? So why am I going to be torturing somebody and telling them, well, you have to kind of focus on dietary and lifestyle changes when they've tried it and it hasn't worked? So now it's a little bit more like open, meaning, it's a conversation that I have with my patients that kind of try to assess, okay, what have they tried? What has worked? What hasn't worked? And taking into consideration their lifestyle and what is at stake, we come up with a plan that works for them, right? And what I mean by that is, say we do the evaluation, we do an exam, we've made a diagnosis, we have diagnosed that it's possibly bladder pain. Now, we didn't talk about some of the testing. So that's again important, right? So I do the physical exam, but that's just me looking at the anatomy. There are some specific testing that I would recommend that patients get if they've not had it done before. Number one being a cystoscopy, which is basically looking inside the bladder with a tiny camera. I mean, think of it as a colonoscopy, but for your bladder. It's of course people with IC, they're already in pain. They're like, wait, what? You're gonna look inside my bladder? But I would recommend getting it at least once, because number one, you don't want to miss anything abnormal, right? Because again, like we talked about, you don't want to just assume everything is IC. God forbid there is cancer. You don't want to miss it, especially if somebody has had a history of smoking, or maybe they've had family history of anything, or there could be a lesion. If you're somebody who has had prior surgeries in the pelvic area, maybe you've had usage of mesh. So there's some foreign materials. You don't want to miss that there's migration of foreign materials in that bladder. So looking at the bladder, and also looking sometimes can show you that yes, there are ulcerations and there are Hunner's ulcers, which is very classic interstitial cystitis. And if I see that, I am kind of leaning more towards treating those ulcers, and I can kind of individualize the treatment for that patient. The other thing, it's not testing wise, not necessary right at the beginning, but at some point, especially if you feel like you've tried a lot of different things and nothing is working, is a test called urodynamics, where we're basically trying to see how somebody's bladder is functioning. And the reason for that is, a lot of women with interstitial cystitis have symptoms of urinary urgency frequency. Some people may have really stenotic bladder, which means that their bladder is so scarred that it's not expanding or holding a lot of urine, which is why they're feeling like they have to go all the time. So doing that testing gives us a lot of information about, what is their bladder capacity? Is their bladder wall spasming randomly when it shouldn't be? So it kind of gives us a lot of objective information that we can use to individualize the treatment. So then with regards to treatment, yes, lifestyle modification, big fan, right? Because as you know, for a lot of patients, it's as simple as just changing and tweaking certain trigger factors, right? Whether it be dietary, whether it be focusing on stress reduction, whether it be, looking into like cognitive behavioral therapy so that they can address some of the stress like we talked about, whether it's anxiety, whatever the trigger is. So that's a big, big component. And I'm always surprised, like, how well it works for patients who really kind of, take it to heart and kind of puts their heart on it, right? And that's a big component. Yes, there are medications, and I'm not going to go into the details, but I always tell patients medications are great, but understand every medication has side effects, right? So we kind of talk about those side effects. For example, a lot of the medications we use are nerve medications, and what that means is one of the most common side effect is it can cause a lot of sleepiness and grogginess. Now you are a young 20 something or 30 something year old functional person who maybe have young kids or has a job. You're not in a place where you're going to be sleeping all day just because you're treating your IC. So we kind of have to think about okay, this is not the, even though I know it may work, this is not the right treatment for this patient. So then we kind of talk about some invasive options, for example, instillation, where we're basically instilling this cocktail of medication directly into the bladder. Again, not for everybody, but I have patients who it works for. So remember earlier you're asking me like, what do patients do? I literally have patients who will call our office and be like, I'm going through a flare. Let's just schedule the installations because it works for them. So that's another option. There's another thing called cystoscopy with hydrodistension. So if I know somebody has Hunner's ulcers, or like their bladder capacity is very small, stretching that bladder sometimes can break through those scar or like scar tissue, and also kind of that hypersensitive nerves can kind of address that. So those are like some of the common treatment options that we talk about. There are some other treatment options that's kind of off label for the pain component of IC or bladder pain, but it is FDA approved for the urinary urgency frequency. Things like, bladder Botox or sacral neuromodulation. So a lot of my patients, if they're bothersome symptoms in the urgency frequency and how much they're going to the bathroom, so then we kind of talk about like some of these more invasive options. So it's a discussion that I have, and based on each patient's symptoms.
Yeah. No, I love that individualized approach. I am a huge advocate for that. I mean, personally, none of the invasive options ever worked for me. None of the
Yeah,
medications worked. And so I was kind of left thinking like, oh, okay, what do I do now? Nothing worked for me. What's wrong with me? But
yeah.
again, there's people that it does work for. Like, so it really just depends.
Yeah. And sometimes it's not one or the other, right? And I think that's something that I always try to emphasize to patients. And I think that's why kind of looking at both the disease process and the treatment from a multidisciplinary approach, a multifactorial approach can be really helpful. And I think it's helpful when both the patients and the physician have an open mind. Like I said, the open dialogue always helps. I mean, there are things that I'm learning from patients. They maybe found something from a support group. In fact, I heard about some of the support groups from my patients. I had no idea before that. And even the fact that I'm doing all these social media stuff is because patients would come and tell me, Dr. Noor, like I saw so and so in this post, and I'm like, okay, I'm just starting my own so that my patients can just find information in my social media stuff. But it's really that because you want to create a place where patients find the right information, and that's evidence based. And yes, sometimes we have to do something a little bit more creative because some of the routine stuff are not working. As long as we have the patients buy in and they understand why we're doing what we're doing. Like for me, like education for what I do, I always say like urogynecology and pelvic floor disorder stuff. It's all a quality of life issue. None of this I have to do. It's not cancer that I have to remove. It is a quality of life issue, and my job is to make sure your quality of life improves than gets worse, right? If that means, we're just having a conversation and you feel better about your disease process, my job is done. And for some patients, it's surgery. Great. Like these are the options. We have the luxury that we can offer starting from conservative measures to surgery. And I think that's the beauty of what I do, and which is why I love what I do, is because there's so many options and it's definitely not one size fits all.
I love that. You sound like a really great practitioner. I wish I knew you
Oh, thank
back when
you.
I was suffering.
Oh, thank you. Well, now you know.
Now I know. But I feel
Yes.
like this is a really great place for us to kind of wrap this up. Is there anything
Yeah.
else you wanted to add? Any words of wisdom for my audience?
I think, the first thing, and it kind of has been the theme throughout, is, definitely educate yourself about your disease process. What are some of the concerns? And then, have an open mind, right? Whether it be with regards to treatment, whether it be with regards to evaluation. I'm a big proponent of if you feel that you saw a physician or a provider and you just didn't feel that connection, or you felt that you weren't heard, get a second opinion, right? I mean, now, especially with social media, there are many physicians or many providers who are making ourselves public, and the idea with that is for you to be able to understand, like what it is that we believe in, and what is kind of what the experience will be when you're listening to us. So educate yourself, and be your best advocate, right? Don't just assume that, okay, it's all in your head. It's not. But also sometimes be patient. Like, just because if you're not seeing some of the improvements, it's not because you're not being treated the right way. Understand that some of these pathologies are difficult to treat. So I think, working with your physician, working with your care team, having that multidisciplinary approach, whether you're working with pelvic floor PT, whether you're working with dietitians, whether you're, listening to, say, Callie's podcast, have that open mind, where, the goal is we're going to work together to get you to a place where you can live your life. Another thing I always emphasize for my patients is this is a chronic disease. Unfortunately, it's not going to go away. And if you're expecting that, you're going to be completely disease free, I think that's not the that's you're probably going to be disappointed. Think about it as like, okay, if you had blood pressure or you have asthma or diabetes, you're going to have this for the rest of your life. The goal is to get you to a point where this disease is not dictating your life, but you can still live your life and be able to manage it accordingly.
Yeah, yeah, for sure. If somebody is looking to work with you, are you only seeing local people right now?
I am. Well, yes. So we are so I'm in the Lehigh Valley, as you mentioned. We have, three other physicians in our practice. I have some wonderful PAs. We're excited and happy to help anybody. But yes, if you're in the area, we're happy to see you. But also, like I mentioned before, I have been very active on social media. I have my YouTube channel, my Instagram, my Facebook. It's all just my name, Dr. Nabila Noor. And the goal with those channels is really to kind of educate women, because a lot of these things that women suffer with, any of these pelvic floor issues, are just taboo topics that we don't talk about, or like know about that this is even a problem. Like, I'm amazed when sometimes women are like, well, that's a problem? You mean like leaking urine is not normal? Is not normal? Like, no, it's not normal. So the goal is to kind of educate. So start there. And, if you listen to it and you find it, please send me a DM. I'll be happy to touch base, and yeah, happy to interact.
All right, awesome. So we're going to link all of that in the show notes, but I just wanted to say thank you so much, Nabila, for coming on. This has been a really awesome conversation.
Yeah, no, I really had a fun time. And thank you for doing all that you do for our patients, and all the best.
Just toot my own horn.